So good morning, everyone. I will be speaking on the study, which was the limbal stem cell transplantation in extensive ocular surface squamous neoplasia, or OSSN. Um, okay. So as we all know, OSSN can involve the conjunctiva as well as the cornea, and the goals of treatment of the OSSN are primarily the complete resection of the tumor, along with prevention of any recurrence and maintaining a good ocular surface postoperatively so as to reduce the morbidity. The available treatment options include surgical excision, chemotherapy, immunotherapy, options of radiotherapy, and in extensive cases, enucleation and exenteration. So the recent trends have been towards topical immunotherapy for most cases of ocular surface squamous neoplasia. However, in extensive cases and in which the depth of the tumor is not we are not sure, surgical tumor excision still remains the most commonly used treatment modality. So this was the purpose of our study, to determine the role of primary or concomitant limbal stem cell transplantation, LSCT for short, in surgical management of extensive OSSN. We defined it as more than 3 quadrants of limbal involvement to prevent limbal stem cell deficiency, or LSCD. So this was a comparative, interventional, multi-center case control study. The centers involved were our center in Ambala, as well as CMRI Kolkata and Center for Sight, New Delhi. We carried out the study from 2009 to 2014. The inclusion criteria included a clinically suggestive limbal mass involving more than 3 quadrants of the limbus, a primary surgical excision with or without adjuvant chemotherapy, a minimum follow-up of 12 months, and no metastasis, neither regional nor systemic. So we divided these cases into historical controls who underwent only wide excisional biopsy without LSCT, and this was mostly in the previous study years, and later on the cases which underwent concomitant LSCT after wide excisional biopsy of OSSN were considered as proper cases. So this was the data recorded, and notable here is the location and extent of the tumor, the limbal involvement, the morphological variant, and the associated features like keratin, feeder vessels, vascularity, and lymphadenopathy. Photo documentation consents were taken appropriately. This was the chart showing details of all the cases. There were 5 cases, and we had clinical features which were these, and there's a pointer here. Okay. We measured the epithelialization time and the outcomes at the follow-up period, and the histopathology was also analyzed. So these were the top 2 were the, thank you so much. The top 2 were the controls, the historical controls, in which only the primary excision was done and covered with AMG, and no LSCT was done, whereas the center one and the top and the bottom 2 ones were taken as cases. So all patients underwent extended tumor excision, double freeze-thaw cryotherapy, and amniotic membrane grafting. 3 patients which were considered as cases underwent conjunctival limbal autograft, or CLAG, and in 2 eyes, and simple limbal epithelial transplantation, or SLET, in 1 eye, according to the standard technique. So now this is the simple diagram showing the epithelium that had been removed after alcohol debridement, and then the surface was bared and the tumor was excised, and then AMG was placed, over which the limbal biopsy from the other eye was taken, and SLET pieces were transferred onto the AMG and glued with fibrin glue, and this was the immediate intraoperative picture there. Outcome measures were presence or absence of LSCD after tumor control. This was a statistical analysis which was done. None of the cases had any tumor recurrence or metastasis. The median age was 62 years. The tumor features in both the cases and controls were comparable. So the average time taken for surface re-epithelialization was prolonged in the controls, whereas it was close to 18 days in the cases with LSCT. The mean time interval between surgical excision of OSSN and onset of LSCD in the controls was 8 weeks. So this was the picture which is showing the post-op LSCD in the form of pannus and pseudopterygium in the controls in both the eyes, and here are the cases which underwent concomitant primary sitting LSCT, which showed hardly any limbal stem cell deficiency even after near total loss of limbus. This is the SLED case. So LSCD in OSSN could be due to the direct invasion of tumor cells, or it could be due to the iatrogenic damage due to surgery, cryo and chemo. People have already studied that AMG per se, only AMG could lead to signs of LSCD, and some have even used conjunctival autograft. But this was a study, a similar study in LVP has said that they have done for more than 2 quadrants, but we believe that smaller lesions may not always need extensive LSCT. So these were the limitations. So restoration of limbal stem cells using LSCT during excision in the primary setting may be pertinent to a good functional and cosmetic outcome. Thank you.